learn, so I hope you still have energy to listen to one more talk. So we talked a lot today already about how to diagnose GIST, how to treat it surgically, what to do if the patient's at high risk for recurrence after surgery, and what to do if actually the GIST was not removed surgically or cannot be removed surgically. We talked how to manage side effects, and we also talked about what's very important about the importance of diet to deal with side effects. I decided to talk right now a little bit about progress in GIST, and some of the slides are very similar to the slides you've seen before during some of today's presentations. So actually, I'm going to skip the slide. You saw with Dr. Singh presented that we should be at least for patients who have high risk for recurrence. So let me make it clear. It's not everybody who has GIST and GIST was removed. This is the patients who were included in the study were patients whose tumors were bigger than 10 centimeters, so bigger than 4 inches. They had high mitotic count, or a high mitotic count, or rather bigger than 5 together with high mitotic count, or the tumor ruptured during the surgery. So this is the group of patients that they are at high risk where disease will come back after simple surgery. And then these patients were offered imatinib after surgery, and we know right now that 3 years of imatinib is better than 1. There is another study, which this one actually was a Scandinavian study. There's a study in the United States. Right now patients are followed for 5 years, and we'll see if 5 years is better than 1 year or 3 years. So right now the question is, what if the tumor becomes resistant to the therapy? And we know that we have 3 drugs approved for patients with unresectable GIST. It's imatinib, it's sunitinib, and regorafenib. What's next? So when we think about resistance, we can generally divide this resistance into primary resistance and secondary resistance. And you had a similar slide in the previous presentations. What it means, the patients who are just diagnosed with GIST, they start on imatinib and the tumor is growing, although they are starting on a miracle pill. And then the secondary resistance means the patients were on imatinib, were on the drug for at least 6 months, and the drug helped, and after that, the disease started growing. When patients develop secondary resistance, it can be in the form of a localized progression of the disease or a generalized progression. Localized means when it's 1 or 2 lesions that are getting bigger, but the rest is under control. And the generalized progression, then actually everything, or almost everything, is growing. So what can we do when we have limited or localized progression? When we have only 1 or 2 lesions increasing in size, then we can change the oral medications. The patient was on imatinib, we can switch the patient to sunitinib or regorafenib. We can think about surgical resection, and there was questions about it before. So if it's only 1 lesion was growing, one can remove it. Of course, we have to weigh against the morbidity of surgery, because the surgery can come also with side effects. Then we can use radiofrequency ablation, very good for liver lesions. And it's very good if you have 1 or 2 growing lesions. It's not very good if you have 20 growing lesions in the liver. Or radiation therapy. The function of radiation therapy by itself is limited. It's very good for painful bone lesions. Gastrointestinal stromal tumor occasionally can metastasize to the bone, especially in patients who had disease for a longer time and it was not under control. So right now we talk about, and I don't know if it's a joke, because everybody has a different explanation. What's a signaling pathway? Because we are talking about, here I'm giving you a course, you're getting a course of molecular biology, and not everybody is a biologist, or not everybody went to medical school. But I see that actually patients with GIST, they read so much, and actually they know a lot about molecular biology. So for me, and actually I borrowed this, it's a little bit like New York. So you are trying to get from New Jersey to Manhattan to work in the morning. And so this is, this is like this kit that people are accumulating over there and trying to get to work in Manhattan. And they can take two ways. They can go and they can get to Manhattan. So it means, when you have this accumulation, like a mutate, kit is a normal protein. What's abnormal in GIST is that this kit has an abnormality, what we call a mutation, and is constantly in an on position. So these drivers constantly rush towards this Manhattan. But if they can take different pathways to get to Manhattan. So imagine if this is something that stops these drivers from going, and when the traffic subsides, and also, the governor of New Jersey can do things too. I don't want you to learn all of this. What I want you to know is that KIT has different parts, and there's different parts of this protein called exons. And patients with GIST can have mutations in different parts of KIT. When we saw the slide from 1998, the Japanese the paper when KIT was discovered as something important in GIST. In 1998, for us it was a great discovery, but we couldn't even figure out how to differentiate GIST from leiomyosarcoma from other types of sarcomas. Then imatinib came, and it was a breakthrough drug, and everybody was happy because so many patients responded. But then we realized actually, how come? Everybody has KIT, but not everybody responds. So we understood, there are some patients who have mutation in exon 11, and these respond much better, and which is this part. Where's my box? Which is this part. And some patients have, this is the second most common, have mutation in exon 9, which is this part. And so we said, okay, exon 11 are sensitive, exon 9 are not sensitive, and the rest we call wild type. As more understanding came, now we see that this wild type means usually we haven't found the mutation yet. This is more or less the message. And we know right now that there might be patients, more common mutations are uncommon, but more common is also exon 13 or exon 17 mutation or exon 18. Of course, here I'm not talking about PDGFR alpha mutations. Based on these mutations, now we know that some of the drugs might be better for the patients with one type of mutation, some of the drugs might be better for the patients with another mutation. So the message from this slide for patients is, if you go and you talk to your doctor, you always ask what type of mutation I have. It might not be, if your tumor was resected, it was a small tumor, which never came back. You may never need this information because hopefully surgery cured you. But it's always good to know. Occasionally we have situations when despite the doctor recognizes that it's important to know the mutations, that is, there might be not enough tissue to test the tumor for the presence of mutation. And it's very often when patients are diagnosed with fine needle aspiration, and maybe they are starting to believe that the tumor kind of disappears and you don't have enough cells to do the test. Okay, so as I told you, this is the mutations in KIT, a summary, but there are also mutations in PDGFR. They are much less common, but they make for about 8% of all GIST patients. And then finally, what we call wild type, which is not really wild type, and we have a patient with a BRAF mutation, RAS mutations, succinate dehydrogenase B deficient GIST, and GIST associated with NF1, which is neurofibromatosis 1 gene. So what happens? We are giving this miracle drug, Gleevec, we stop the traffic, nobody gets to Manhattan, or everybody's happy. Suddenly somebody said, I'm going to use my GPS and I find a way around it. So I'll find the side streets and I will be able to get there anyway. So this is kind of what's happening to GIST when it's not that the tumors are so smart, but there might be cells that have pre-existing mutations or the cells can develop new mutations and they become resistant to imatinib. So actually I found this a kind of interesting paper. And I think, I'm not sure if they are completely right. So there is a group of mathematicians who took patients with GIST and what they learned about patients with GIST, and they analyzed the size and applied mathematical formulas, and they say, what's the chance up front when the patient has this size of the tumor, when they might already have a mutated cells in this tumor that might be resistant to GIST. And they came up with this curve when they had about 200 patients they could compare, and he said if the tumor is bigger than 6 centimeters, it's almost sure that there are some cells that are already resistant to imatinib in this tumor. We may not see that, patients may respond very well, but if you continue, the cells may outgrow. So in this way, I think it's very scary, this mathematical analysis, and you have a tumor less than 2 centimeters, the chances are almost zero that you have resistant cells. But we have patients who had larger tumors than 6 centimeters and it just never recurred, or they had multiple tumors that altogether make more than 6 centimeters. So I think it's interesting because I like mathematics, but I'm not sure if it's always true. So how do we develop this mechanism of resistance? It can be a series of this primary resistance up front, what we call wild type. So this is maybe some of PDGFR mutations are not so sensitive. Then finally we know that patients who have exon 9, if you use 400 milligrams of imatinib a day, this dose might not be sufficient to control the disease, but when you went to 800 or 600, then you may be able to control the disease. As I say, the patient may develop new mutations. These new mutations might be pre-existing in very few cells, so initially you don't see them. But if the other cells are under control, the ones which are resistant, they start growing. Or what is very often problem in resistant GIST is that not every lesion in the body that's growing must have the same secondary mutation. So it can happen that one lesion develops exon 17, one lesion exon 13 mutations, and each of them will be sensitive to different drugs, which makes our life, of course, difficult to treat. So what are the new approaches? We know that when GIST can find their way around imatinib, they can find their way around imatinib. They can find a way around sunitinib, and they find a way around regorafenib. So one of the concepts is, what if we block not really where the GIST is, but maybe we should block somewhere downstream, not on the level of imatinib. Like, let's block both tunnels and see if they can get to Manhattan. So this is again a very similar graph as Dr. Singh was showing. This is the signaling pathway. So this is kind of everything starts located in New Jersey, and then you have different tunnels that you can get to Manhattan, that they can lead to cell proliferation. So most of our drugs, all the drugs which are actually approved, they work on GIST. Some of them have some activity against PDGFR. But if we see this can go different ways. So people are trying to develop, some of the drugs are already approved, to inhibit maybe an mTOR pathway, to inhibit the BRAF pathway, so RAF or MEK, to intervene on the level of the protein with drugs like bortezomib, or maybe on the level of DNA, so where the KIT is synthesized, we can block the synthesis of abnormal KIT. Finally, there are some efforts. KIT must be appropriately folded to function, and there is a protein called HSP90 which is responsible for folding of this KIT. So if we can stop this protein, the KIT will not be able to assemble itself. So I'm going to talk a little bit about currently available oral medications. They're available theoretically on prescription, but they are not FDA approved for GIST. And I have to say, this is always a problem because these medications these days, when new medications are about $9,000 a month, this is the regular price, and they are not covered by insurance. This makes it difficult. Some companies have very good assistance programs. Some companies don't want to assist because they are afraid that it could be considered a promotion of a drug for an approved indication. And of course, this can lead to the lawsuits and so on. So one of the drugs which was mentioned is sorafenib, and actually we have quite a lot of data on sorafenib, like an example of this trial which was published. This is a slide from our oncology conference showing that in all patients who progressed on imatinib or sunitinib, the stable disease or stable disease responses were seen in about 76% of patients. So it means you failed imatinib, you failed sunitinib, but when people tried sorafenib, and about 76% of patients benefited from sorafenib. What we do not know, and this is again the slide from the thing, is there a difference between sorafenib and regorafenib? We know that this drug, when the studies on sorafenib were done, we did not have regorafenib, and the company took regorafenib to development. So right now, we will be, as people will progress, or the disease will progress on regorafenib, we will try to expose them to sorafenib, we will know a little bit more if this one group actually matters or not. Because we know that the side effects are not exactly the same. So we know that this group matters. But what's the efficacy against the GIST, we don't know that for sure. This is nilotinib. Nilotinib is a drug that's approved for chronic myelogenous leukemia, for type of leukemia, and we know that it's better than Gleevec for patients with leukemia. More patients respond, and the response is more durable. So the natural thing was, Gleevec is great in leukemia, Gleevec is great in GIST, nilotinib is better in leukemia. Let's see if nilotinib is better in GIST. And we have actually some of the patients here who participated in this clinical trial. The patients were randomly assigned. Either were getting nilotinib, 400 milligrams twice a day, or imatinib, 400 milligrams daily, and if the disease progressed, they could switch over. So actually the study was stopped early. The study was stopped early because it looks like when more patients had disease progression on the new medication nilotinib, and more patients died on nilotinib than on the patients who received. These numbers were still small, but the difference was significant. So something what's called Data Safety Monitoring Board made said you cannot continue this trial. You should offer imatinib to everybody who received nilotinib. Because although nilotinib is better for leukemia, nilotinib is not better for GIST. And we see that the purple curve is for imatinib, the blue for nilotinib, and you see obviously just imatinib is better than nilotinib. One of the major differences is that nilotinib has, and this is for patients with exon 9. Now, as you see, almost everybody with exon 9 progressed immediately. Patients with exon 9 who achieved imatinib, some of them progressed, but many of them had control of the disease. So we see that nilotinib is completely inactive in patients with exon 9 mutation and should never be used in this population. That's why, again, I'm going back to the message. You need to know, these days, and we are getting smarter, if you are treated with this medication, you must know what mutation you have, because based on this, we may choose the drug. What about ponatinib? Ponatinib is a new medication which is kind of available. It is approved again for CML, for patients who, and I'll tell you why we mean by kind of, because for patients with CML who progress on available drugs and had very rare types of mutations. So this drug got approved and then was taken off the market because of increased risk of liver toxicity. Then they added this liver toxicity label, and FDA allowed the drug to be put back on the market. But actually there was a study of ponatinib in patients with GIST, and this study was stopped as far as I know, and I don't think there's any approval to the study. So this drug is available, but might be very difficult to get the drug for patients with GIST. And we know right now that it binds to, we know that it can bind to KIT in a little bit different location than imatinib or sunitinib. So again, when we go to mutations, if the patients have secondary mutation in exon 17, actually ponatinib, which is the blue line, is better. This is in animals, so this is not patients, it's in mice. We always cure a lot of mice. But so these are animal studies. We have to translate it to humans. We don't know if it's going to be the same, but this is how we start with animal studies. But we see then ponatinib might be a good option, but not for every patient again. So we need to know the mutation status. What if, we have, and there is, I didn't talk, I don't have as many insights on dasatinib. Dasatinib generally is considered when we take all patients with GIST, it has very little activity. But maybe patients with this red PDGFR mutation, it may have some activity. So it would be the therapy for them. I don't have slides for them. So what if all the available therapies stay when we don't have any other therapies? Recently there was a study where saying, let's say there were patients who benefited from imatinib. Then they went to another therapy and another and so on. But right now we ran up all the options, what to do. So these patients were randomized back to imatinib, or we will say, okay, we have no other options, so we'll offer supportive care of placebo. And we see that actually the disease, it took a longer time for patients to progress on the drug that benefited them before than patients who were on placebo. Which tells us right now that even if your disease progresses and you run out of the options, you probably should continue on the drug which will have the highest activity in your case, although the disease is resistant. It also questions our clinical trials, and these days people ask, can we, with new clinical trials, can we offer even placebo, or we should offer another drug when it's compared to the new drug. We didn't see so much improvement in changes in overall survival, but at least the progression of the disease was delayed when the imatinib was restarted. So, a few words about therapies in development. One of the concepts is maybe we should combine two TKIs. And actually here it's a case only. The patient was started on imatinib, progressed, was given sunitinib, progressed. So there was given sorafenib and partially started, initially responded, partially started progressing. So the doctor says, instead of stopping sorafenib, let's add imatinib, that is the first drug, back to sorafenib. So the patient right now is on 2 TKIs, on 2 drugs. And we see that the patient had about 2-year control of the disease on the combination of these 2 drugs. There is another study, I don't think it's been published yet, so that's why I don't have a slide, but it was presented. And people are trying to use, since it's possible that different mutations are in the same patient, so maybe we should combine sunitinib with regorafenib in patients who progress on imatinib. And the side effects are similar of these 2 drugs, so very often if you take 2 pills at the same time, the side effects may go high. So the concept is like that when we do 3 days of sunitinib and 4 days of regorafenib. Then we just, in a week, we'll do 3 days of one and 4 days of another. There was some activity. It was too early to say if this concept is going to turn out, but it's a smart concept. When we try, in the patient who progress on first or second attack, we'll try to block in different sites on different days. First, as I told you, there's some interest in maybe if we could stop the production of KIT and the level of DNA with drugs called histone deacetylase inhibitors, there would be some activity. So this is a very early study, phase 1, with, as you see, with a very small number of patients. Then the drug called papinostat was combined with imatinib. These are the results from the PET scans. As you see, it was in this small study, only 3 patients had reduction in the activity on the PET scan. But when you look at the number of, there were no objective responses. What we mean by objective responses, reduction is assessed by at least 30%. But at least 8 patients had stable disease that did not grow. But the duration was only about 6 weeks. So probably we might not be the home run with the drug, but this is something what we try to work on to see if there is another way and to try to stop GIST from growing. Other drugs, as I said, on this pathway downstream from KIT are PI3K or mTOR inhibitors, and this is this drug that does not have this name, GDC0980. There was a 2 phase 1 studies, and about 17 patients with GIST were included. It's difficult to say, it's a very small number, but there were some patients with a very long control of the disease, and this is somebody with SDH deficient GIST, which we would call normally wild type. It's not a KIT mutant GIST. EGFR mutant GIST had a longer time on the disease, and then there were two patients, they didn't know the mutation status, and then there was one with exon 9. They had a longer benefit. So the question is what to do with this wild type GIST, and we don't know. Generally, we still often say exon 11, exon 9 wild type. Now we are smart and say, wild type is not a good name because we know other mutations. So I mentioned before, there might be different mutations. It can be a BRAF mutation. Some patients we may not find the mutation, but may have an increased expression of the protein called IGF-1R. Then mutations in the succinate dehydrogenase, or mutations in NF1. So there was studies showing, trying to look at the wild type GIST and looking at this expression of a particular protein called IGF-1R. If patients had mutated GIST, as you see, the brown means that it's present. So if they had KIT, but they did not have IGF-1R. But if they had wild type GIST, so the mutation in KIT, they were not able to find mutations in GIST, they had also expression of IGF-1R. So the question was, can we block IGF-1R and see if we can have our patients with GIST? And this is a study of an oral IGF-1R inhibitor called lenvatinib. As you say, again, there were no responses by RESIST, but we see that there was at least, here in the small group of patients, 3, 6, 7 patients, they had reduction in the size. The studies most probably will not be taken any further because they did not meet a predetermined endpoint. But we see that some patients benefit. We just don't know how to identify those. And maybe if lenvatinib alone is not beneficial, maybe we can combine with other therapies. This will be the way to go. And as you see, there's information about progression and overall survival. So we see in some of the patients, 11 out of 20 patients had stable disease for more than 6 months. It's not the KIT mutated, it's where there's wild type patients. So what are the clinical trials right now ongoing? There is a trial of imatinib, a MEK inhibitor, imatinib and everolimus. We in our clinic very often use this combination. We add mTOR inhibitors to many of our patients who progress from previous therapy. There were 2 clinical trials of HSP90 inhibitors different from this drug that failed, did not meet, and we don't know. There was so much great data in mice, and there were pre-clinical data and early clinical data. When we ran 2 larger trials, there was no benefit in patients, but there's this one which is still being tested. Actually, I think this study is only in Taiwan, but people are trying to see if they can use another HSP90 inhibitor. Then PI3 kinase inhibitor in combination with imatinib. The new TKI on is masitinib, and then they are running a large clinical trial of masitinib compared with imatinib. Then there's some interest in using CDK4 inhibitors like palbociclib. There's a trial of immunotherapy with ipilimumab. We don't have much information about immunotherapy in patients with GIST, so this is a new approach. And then finally, we are waiting for the results of a trial with crenolanib, which is a PDGFR inhibitor. And I know that the accrual was finished. I think the patients that follow will see this rare population of patients who just may benefit. We did run a clinical trial with an antibody against PDGFR, and there was not enough activity of antibody alone to justify further development, so the trial was stopped. And we'll see maybe oral smaller molecule will be more beneficial. So there's very few slides. I said, what if we said that chemotherapy doesn't work in GIST? Should we maybe go back and revisit chemotherapy? This is somewhat preliminary, but people did, they had a library of different FDA-approved compounds, and they had 5 GIST cell lines and said, let's do massive sensitivity testing. And then if it's red, it's effective. If it's green, it's ineffective. And when you do a highlight, and we see that For example, bortezomib, which is a drug approved for multiple myeloma, was effective. This here are leiomyosarcoma cell lines, which is a control, was effective in some of the GIST cell lines. Also, dactinomycin or nitramycin A, not in all GIST cell lines, but it was effective in some GIST cell lines. And mitoxantrone was actually effective here in one GIST cell line. So it tells us, then maybe if we know how to identify these rare patients, it's not going to be in every patient. We will revisit chemotherapy. This is too early to offer chemotherapy right now to patients with GIST, but it may happen that if we are able to do this testing, we will be able to offer chemotherapy to benefit patients. The last slide is about radiation therapy. In GIST, it has a very limited role. As we have to remember that there's a proximity of vital organs. GIST is usually in the abdomen, so it may be proximity of kidneys, liver, spleen, and bowel. Therefore, the side effects might be increased. But if a patient has a bleeding tumor, radiation therapy is very good. If a patient has painful lesions, then radiation therapy is very good to control pain. And again, radiofrequency ablation or stereotactic body radiation might be helpful if there's a growth of one or limited number of lesions. So the message from this presentation is we do have three drugs. And of course we extend life of patients with metastatic GIST. There are patients whose disease never progress after imatinib, and they can stay for 10, 11 years. But unfortunately, this number is probably in the range of 20-25%. The rest of patients who have metastatic disease, the disease will start to grow. Patients live longer and feel better, that's why they go to the second and the third line of therapy. We need new therapies. Generally speaking, probably combination therapies will be the way to go. I always give this example. Patients who were initially treated with HIV were treated with one drug. These days, no one would say that I will treat the patient with HIV with one drug, and if this drug stops working, then I'm going to give them the second drug. If it stops working, then I'm going to give them the third drug. So probably this is the way to go also with cancer, and it's a little bit easier with HIV because the targets are not our normal proteins, so we are targeting the proteins which are virus specific. Here, as we start targeting more proteins, which are normal in our human body, because we need mTOR, we need RAF, we need RAS, we all need for our cells. So we start targeting these proteins, it may happen that we will develop more side effects. So it's a little bit more difficult, but I think the combination therapy would be the way to go. Okay, that's all for now. Any questions?
I know the diabetes drug metformin is being evaluated as an mTOR inhibitor. What do you see in that, and what types of dosages are really?
So we see that some of the patients who were treated with metformin may possibly develop less cancer, and we see it in breast cancer and it's a little bit in pancreatic cancer. We don't know what's the right dose of metformin, and we actually do not even know if it's an active drug. So my answer is I don't know. Yes, please.
Have there been any trials that check if you start with two therapies in the beginning, if you have less mutations in the long run?
So as I'm just saying, there is this trial which we do not have published results as far as I know yet of combination. It's a small group of patients. Mainly they try to find and see if people can tolerate the doing sunitinib and regorafenib, and this is on kind of 3 days and 4 days in a week. So this way. There are trials of imatinib and mTOR inhibitors like everolimus. Yes, so a little bit, but this is not a large number of data. It is this is actually maybe it's counterintuitive, but I'm gonna I always show my philosophy. But so actually, just to some degree, is a victim of its own success, I think, because imatinib is so successful and it's great. So I don't want to try to criticize. then we kind of said, oh, we are happy because we have imatinib. If imatinib would be less successful, sooner we will be starting looking for combination. I mean, it's a little bit silly what I'm saying, but it is like that. Since we had one successful drug and the second that helped so many people, it was not that they stopped, but looking, but it's not that necessarily the scientists stopped looking, but the companies to invest in the development of the drug, they became less interested because the market is so small. Yes, also.
Is there a test, and if so, is there a need to have your children tested to see if that was passed on?
I'm sorry, say again?
Is there a test, and if so, is there a need to test your children to
Oh,
see if the...
So actually just can run in the family, but we would run in the family in fewer than 1% of patients. So normally there's no need, especially if you have an exon 11 or exon 9 mutation. If you have NF1 mutation, which is the gene associated with neurofibromatosis, or if you have succinate dehydrogenase B mutation, this can be passed. So this is more reasonable to test. Otherwise, I would say there's really no need. One of the things first, I would test the patient before you test your children, because the mutations which we talk about are just mutations in cancer cells, not in the rest of cells of your body. So you have no chance to pass because it happened only in cancer cells. But there are these few patients, and I'm just saying, fewer than 1%, especially the ones with NF1 mutation or SDHB mutation, not KIT mutation, that may have this mutation in all cells. And then these can be passed. And this we can test, but ours, I say, I would recommend definitely against testing.
We talked of taking a vacation earlier. Can you take a long enough vacation where you can plan to have another child?
Yes, you can. Yes, you can. Okay. Any other questions? Okay, so this is the end. I don't know if I really want to say anything else, but I wanted to thank you all for coming here. I hope you learned something. I hope you got some information, and I hope this time was well spent. I want to thank very much Barbara for helping us and for organizing the event. I want to thank all the speakers, Dr. Albert, Dr. Singh, Caroline, and Sandra, for coming here and devoting their time and effort to this meeting. And I hope we can continue that maybe annually, so we can keep you posted on the new developments in this.
First of all, I want to say that we have cookies and refreshments out there for all of us if you want to visit and meet one another and share. I want to thank all the speakers. Thank you so much for giving your time and your expertise. It means a lot to us as patients to be able to hear what you have to say and learn from you, and also it gives us a lot of hope to hear what you speak about, and that there are other lines of drugs that are out there. So we can't thank you enough, and we would like to make this an annual event. So thank you all for coming, and I hope you'll come out and visit for a while.